really good story from when I used to live up in Duluth and work for the Department of Human Services. And part of my job there was to be an advocate for to the 7-county Arrowhead region agencies up in that area. And we had one school, it happened, the school called me one day and said, we're really having a problem with this. The parents of this one student, the parents are deaf, and the student can hear. And the parent is, or this child is failing their courses, and we've told the parents this repeatedly, and they don't seem to be helping us in any way. Shortly after that, the parents called me and said, we just found out our student is failing, and the school hasn't told us anything about this. You know, we've been trying to work with her, and we don't understand, and we think everything's going well. The more I dug this, I finally asked, well, who was the interpreter? And the school district said, well, the daughter. Okay, this 5th grader was interpreting for mom and dad and the school. And the school would say, your daughter's failing her courses, she's not doing well. And, you know, little Annie or whoever it was turned to mom and dad and going, A's for all my courses, doing really well. And parents would look at the school and nod, and the school would look at the parents and nod, and everybody understands. And the kid's getting away with murder, you know. So we resolved that one, but that's a simple example of whose interest is communication control. It was certainly in the interest of that child to control communication in a particular way. I've had other experiences where out of the nature of the relationship, kids have not wanted to tell mom and dad that they're dying, you know, but the doctor feels that information has to be conveyed. Well, how could you pull a child in to do that, you know?
Or just developmentally, when children are asked to interpret for their parents, you know, an 8 or 9 or 10-year-old is a very concrete thinker, cannot think abstractly, and the doctor's trying to communicate more abstract ideas to a person who could understand as an adult. It just, you're going to miss the boat completely. I do have experience where sometimes a patient isn't patient enough to wait for an interpreter and wants to use a family member, so we'll get going with that. My goal is always that before they leave the encounter, we have a non-familial interpreter. And when I worked in the ER, sometimes that was at discharge, and I would write my notes for discharge to my nurse in English, and the nurse would take the time with the interpreter and the patient to go over that to make sure that things were understood.
I'll tell you real quick my 1-second horror story. So my mom, when I was younger, I was pulled up to interpret for her, and she had a guy doctor and a male doctor, and she needed to get a pap smear. And I was probably a 5th or 6th grader, and I had to interpret her a pap smear, right? And of course I used my blunt terminologies that I knew as a 5th grader. And then she cracks up, right? She starts laughing really loud. And then I start laughing because my mom was laughing. And then the doctor was the one that felt embarrassed. Sitting there, just turning around my head. No clue what was going on, but assumed, of course, that we were talking about the important bee, right? That was one horror story. There's so many horror stories, but definitely you have, you know, those types of situations that happen with family interpreters. And then you also have situations where, you know, we had a recent situation where the uncle has cancer, and the kids want everything to be done to help the father as whatever is needed, but the father no longer wants the care. And so the kids are interpreting what they want, and then turning around and interpreting it to the father, but then arguing their point before turning back to the provider and then interpreting again what they wanted. And that is not in the best interest of the patient. So these are just small examples, but it's a huge issue.
Well, yeah, if I can add, Catherine, in your example, I think that's great that you reconfirm all the information. And I think adding to that, the importance of trying to strategically figure out how to move family members out of the situation, so that you can have that private and confidential communication with the patient through the neutral interpreter to reconfirm what truly is their desire, so that you have exactly what you're talking about, communicating.
I think absolutely. I've had patients that straight up will lie to me, but they do so to preserve their privacy in space with someone else. And then they will come at a later opportunity and explain that that's what happened. I will frequently have patients arriving, say a husband and a wife, who, even though they're being treated separately in separate rooms at separate times, want to be present during, an initial conversation with each other. And that gets into some really interesting boundary issues, particularly if one is providing the interpretation for the other, and again, either doesn't want to explain something because of a gender-sensitive issue, or because they have a different opinion about what their loved one's health should be. And I just want to bring up, I think the most, if personally frustrating example in my own practice so far had been a patient who had suffered brain damage and had lost her ability to speak. Her tongue would not move properly, and she did not speak English prior to that. She always spoke Somali. So her ability to communicate, since she was illiterate at that point, was regarding to pointing, smiling, and gesturing, which was then interpreted through her mother, according to what her mother wanted that healthcare to be. And I feel guilty to say this, but I felt an overwhelming amount of relief finally when my professional relationship ended with those patients, because I didn't feel able to realistically provide care in a safe way that I knew the patient wanted versus that a family member did. And so the best I was able to do was to try to find language lessons, maybe I overstepped by doing this, that would be taught in Somali for people who wanted to learn to write, and provided that information to them.
The other issue I found in the situation sometimes that there may be issues of abuse going on, and the perpetrator may be actually the interpreter or in the room, and they're not really willing to come. The person, the patient isn't really willing to speak freely, and maybe even with them out of the room, they're often reluctant to even want to speak, so it gets more complicated.
My mom, she's here. And growing up, because I was a deaf child, my mother always felt it was very important to have an interpreter. And even occasionally when we couldn't find interpreters at appointments, my mother would unwillingly interpret for me, but she knew that that was important. And it's not a good idea to have kids interpret for their parents either. And we don't often have practitioners who know sign language, but when we do, that's certainly fortunate in those situations. It's rare though.
And then specific to mom, which I don't know if this happens in other ethnicities too, but we're all related somehow, right? So from an interpreter's perspective, what I do is I do my best never to find out how they might be related to me, because then it ends up being a family interpreting it, right? Because then what happens is they'll start, and the patients always, especially the older ones, they always want to say, oh, who are your parents? What's your clan? Or what's your last name? And eventually they're my uncle, right? Yeah. And so then they're not going to open up to their provider. And so I try to do my best to introduce myself and get to know them a little bit, and then I distance myself a little bit until the session comes up, until the appointment comes up. Or I'll try to talk about other stuff and not family related. Or sometimes I have to just flat out lie to them and pretend that I don't know who my grandparents' parents are, right? Who my great grandparents are, because if they don't know who my parents are, they'll ask for my grandparents, and so on and so forth until they're like, oh, so you're the granddaughter of such and such, who is the auntie of such and such. That's how we're related, right? So then you have to just be creative as an interpreter and distance yourself, because you don't want to turn out to be family or a friend of another friend. So that initial communication piece between an interpreter and the client is also very key here, to just try not to become someone that they are related to, or else they're not going to open about it.
And that's a great point, because it's very true in the deaf community too. it's a way of establishing your credentials with the patient. That kind of, what gives you the authority to be here as an interpreter? You know, so for interpreters working within the deaf community, you kind of have to, if somebody doesn't know you, they're going to want to know, well, did you just take an ASL class, or are you truly an interpreter? And then they want to know who you know that has authority, that then they can go, oh, okay, I'll trust you. You know, it's that, but it's a tricky dance. You want to give them that information so that you have that trust, but you don't want to give them the sense that, oh yeah, and I'm going to go over to them and then tell your whole story. It's that, it's a tricky dance sometimes.
A little tangential, but it's tricky anyway. I'll cover the year out in Litchfield, Minnesota, and I'm from central Minnesota. And both sides of my family have family in the Litchfield area. And so people say, well, Kramer, who are you related to? When we start talking. And I don't realize that a couple of my relatives don't have the kind of credibility that I want to claim them.
So I think the take home then is that using families is a bad idea, and the low end, and a complete boundary violation at the upper end, which then comes to this issue of cost, because whether it's the cost of time or the cost of money, dollars and cents, I think we have established as part of this discussion that attaining cultural competence, that providing the best possible care for all of our patients, that bridging this gap comes at a cost. And so I guess my question then becomes, what do we do about that cost? How do we still manage to do this right in spite of the cost? And I would just add one small piece to that, because most of the students that we train really still end up in private practice. And so most would say they don't have the resources to hire an interpreter, because sometimes the cost of the interpreter exceeds the cost of the patient visit. And so then what is the response to that? I guess I'm going to throw that out and allow you to just take it however you want to take it.
So my practice is mostly with insurance, and I'm really, really fortunate that the Minnesota Care medical assistance plans, which make up the majority of my low-income patients, do provide for the interpreting and medical assistance. A lot of providers don't realize that while an agency might not have a contract, you as a provider can bill the government for that time that's been spent. And so I do. I write up an independent contract for any interpreter that is bringing a patient in under that way, if they're competent to provide that care. And then we simply pay them out of pocket. But the flip side of this is that I've had people that work as part of agencies that go on to become friends, and they tell me that the cost to the government annually in Minnesota is just staggering for the number of visits that are done. That there are people who artificially inflate the number of visits that a patient maybe has, because that patient is a commodity to that interpreter. And obviously that's not something that a lot of people have considered before, that there's financial bonus to the provider to see patients, obviously. Well, there also is for the interpreting groups. And so there are people that do not do as well, and there are agencies that have very good reputations and agencies that have very loose regulation and loose reputations on this. So when you ask what the cost is, well, there's a cost to the government because I'm going to spend more time with the patient. So there's a good chance that the visit itself might be, if it's a consultation, coded at a higher level because of the amount of time that we need to spend to cover and competently gather those examinations. There's a chance that the cost is going to be higher because of billing for the interpreting service through an agency or directly in my case. And then there's a cost because there are a lot of people, I think of them kind of as opportunistic, that I see coming into my practice, and usually you can get a pretty good feel whether or not they are just shopping a patient's ailment around so that they can make as much money from a sick patient as possible.
One way that this is dealt with in the emergency department, both from a cost standpoint and from an easy accessibility standpoint, is to use video interpretation. You definitely lose something with video interpretation, and as we mentioned, especially in sign language, And actually, in the emergency department, my experience has been we've always managed to get a live interpreter. But with Hispanic, Somali, and then other languages, because you can have anybody walk up the street speaking anything, the video interpreter services that I've used have been almost instantaneous to have an interpreter. And that's a luxury in the emergency department, especially in any language, if you will. And my understanding is that it's a little more affordable as well. I haven't checked into the numbers. I'd be interested to know if anybody here has information from the patient side, how that, I know you mentioned from the sign language experience, that's not so good, the video interpreting, but other experiences too.
Well, yeah, in my experience going to appointments where I asked for an on-site interpreter and not finding one, and then being presented with video remote interpreting, the first time it was new, and I thought, okay, let's try this. But it was really hard to see the interpreter, so we had to move the screen really, really close because it was small. And then I had to move away from the screen in order to be able to be seen on camera. So just the technology issues alone of the back and forth were challenging. And maybe, there are other deaf people here, and other deaf people's experiences are different. So having an on-site interpreter is really nice. But I realize that gets into cost. Other health departments that can't provide interpreters, not all do, some don't for whatever reason, and some think that video remote interpreting is the best option to go with.
Yeah, it's long been a dream of certainly sign language interpreters in the deaf community to have the Star Wars. If you can think of Princess Leia, when she said, "Well, help me, Obi-Wan," to be able to put that disc there in a hockey puck and have your interpreter holographically come up. That I think all of us would love to see. We're not there yet, but it is, yeah, someday, that would be really cool. And VRI is amazing when it works well, and horrible when it doesn't. And part of the issue too is we don't know where it works best yet. It has not been fully exercised. And unfortunately, a lot of health systems are looking at the per minute cost, because the way they bill VRI is per minute. It's a higher per minute charge, but it's less, oftentimes fewer minutes. Or that's the perception. The University of Texas was doing an interesting study, and they found out that their costs actually doubled when they used VRI, because the perception was that it was easier, it was on demand, it was only for the purpose of the communication, but I don't know the full story there, but it was much more expensive. Yeah. In Minnesota, too, the other thing that we have to keep nationally, we have to keep in mind, and the two areas get confused, that American Sign Language, the demand for American Sign Language interpreters is actually a stipulation of the Minnesota Human Rights Act, the Section 504 of the 73 Rehab Act, I may have that year wrong, and the Americans with Disabilities Act, Amended Act, all have very strict stipulations. None of that applies to spoken language requirements, which are actually under the reinterpretation of the 64 Civil Rights Act, section, or Title 6 or 7, I can't remember which. The stipulation there is that it's the provider's responsibility to ensure that patients have clear communication. In all the disability laws, it's that you have effective access. And so, even though they're both interpreters, you're looking at the sign language interpreter like you're looking at the ramp into a building. So the obligation is actually on the provider. And you can't, if the insurance would pay, great, but they're not obligated to pay, like they are under the title of the 64 Civil Rights Act. So it gets complicated. The other thing to know in the Twin Cities, or in Minnesota, our deaf community is litigious. deaf community. They have fought for their rights to appropriate access, and every major health provider in the state has been sued now, at least once. The most recent was Mayo, and Mayo either never settles, they settled on this one. They have their lawyers and they'll fight anything, but they actually found themselves in the wrong on this one. And oftentimes there are a whole variety of things, reasons. And I'm not to send that out as a scare tactic or anything, but cost of access is a real issue, but the balance is the cost of incorrect communication and what could be the resulting error or harm that could happen. And unfortunately, we've had evidence across the health systems of real harm being done multiple times. And so in the major health systems, they've got a structure in place now that seems to be responding really, really well. But for private providers, I don't know, it's a real challenge. And it almost, the one thing I could offer is an interesting response was what happened across the health systems. The only place that they collaborate in services is in the provision of sign language interpreting. In the Twin Cities, there's something called the Minnesota Hospital Consortium, where all hospitals participate. They pay into a single pot. That ensures that there's 24/7 access to interpreting services. Interpreters are on the ready, can be dispatched to any health provider, urgent and emergency care, and guarantees that the person will be on site in less than an hour for whatever need there is. So is there a place for a co-op system in communication access? It's a question.
So before we go on from that, just give me 1 second, I would just like to remind you all that in your packet, you have a blank sheet of paper. And that is if you don't, when we come to the Q&A in about 3 minutes here, if you don't want to actually ask your question, you can write your question down and we'll get it asked, and just hand it to either Donna, or hand it to Donna in the back, and we'll get the question asked and answered for you. Please.
And then just for cost and cost effective and, from the perspective of perhaps family and patients and experiences with that, especially with the video interpreting, what I've seen is usually in the community, there will always be 1 or 2 people staying with the patient all the time, or they'll want to be in the room overnight and things like that. Sometimes you run into issues with providers. But what's been happening with video interpreting is if the doctors are coming to explain something that's going to be in depth, then it's always better with an in-person interpreter. But if they're just coming back and they're going to do some blood samples or things like that, definitely by all means, the video interpreting will will suffice. And what I've also seen from family members too is they're okay with that. So from a patient's perspective, it depends on what it is that the provider is going to talk to them about. And it's simple things like raise your hand, I'm going to take your blood pressure, things like that, definitely. The video will be very cost effective, and patients seem to be fine with that. I've never seen a patient that hated it regardless. Yeah.
I was just going to say, using the video interpreter services got rid of the question of family interpreting. We had the TV into the room, and what we used is a TV screen. It's about that big. And we reel it in and we dial it up, and there's no question that the family's going to interpret. They can participate in the conversation, but they're not going to interpret.
So I'm going to open it up for Q&A, and while we're doing that, I also just like to say to the panelists that I'll be coming back to you at the end with some closing comments. And I'd like you to be thinking about this idea of, again, bridging the gap. If you had one pearl that you want to throw out there, recommend either for patients, practitioners, providers, educational institutions, what might that be? While we're doing that, I'm going to throw it out to the audience. Do we have any questions? Yes. Can we get a mic maybe so that we can?
I've been sitting here waiting to explode. Oh my gosh. My name is Gail. I was a former student here, and I took a leave of absence from Northwestern Health Sciences University. Now, what I will say to that, first of all, is, man, I didn't realize how much I learned until after I took the leave of absence, because now all this stuff is just flooding to the forefront of my brain about what I've learned here. So thank you, Northwestern, for that. Appreciate it. On another note, I also have considerable experience in the mental health field. And I would like to say that you kind of missed that piece. So, but that right there is just a side note to how I would like to address Mr. Sandberg's particular concern, frustration, and lack of respect in the medical field with respect to how services are being provided to him as a person with a hearing disability. And first of all, I want to say that I want to say out loud that I heard you. And I think that other people have heard you, but I think we're still kind of spinning our wheels on where to go with that and how to address it. So what I would like to do is I would like to provide some suggestions for that. I have about 5 cards. I mean, I'm listening intently to everything that everybody is saying here. And I think where we get stuck as a culture that provides services, especially when we're practitioners, is that we're so overwhelmed and overburdened with the responsibilities and tasks that we're mandated to implement, that we don't think outside the box. So, where do I start here? And I won't take up a whole lot of time, but I want to say that Mr. Sandberg's disclosure about his frustration of providing his own advocacy at the medical appointments via video conferencing is insulting at best. And let me tell you why. The barrier to that is, first of all, the interpreter services are very expensive, and we just addressed that particular issue. And it's almost expensive, as expensive as the EpiPen, okay? Because that's just ridiculous. A $600 EpiPen, are you serious? Just to serve people who need this, who need the resources?
There is a generic EpiPen. Pardon? There's a generic EpiPen that only costs $100 only.
Right. But
So I want to make sure that we sort of restrict the conversation to the topic.
right, and I understand that, but I'm not going off topic. It was supposed to be a joke, but anyway. Okay, so what I would like to say is that the accommodation could be for this particular services to address language barriers is to have better contracts at the hospital and care with healthcare professionals to provide lower costs to those people who need the services. And how you would do that is you would design a unit, if you will, at any particular hospital or healthcare facility to specifically and only address those issues. If you have that housed there, then that will lower the costs. And let me tell you how you lower the costs. You provide resources on television and radio, Pandora, Napster, Spotify, web resources. You have to think outside the box. We are in a whole different kind of information system, and we're not addressing that particular thing. We have young people who are deaf. We have young people who are speaking Spanish, and it's almost the main language here, next to English. And how many of us, me included, don't know how to do that? And so if you have those resources there, and you develop a specific and designated resource in a healthcare agency only to manage those services, you'll find that more of the populations that require those services will come. You know that old adage,
If you build it, they will come. But if you're not following through on the resource that you're claiming to provide, then they're not going to come. So then you're not going to meet the needs of the population because they're not getting served. And so their health care is going to diminish because of that. But if you think of it in a different way, and then if you go legislatively, and you have people advocating, and you do it consistently, then those services can be provided for those people. The other thing, and I really am so impressed with Mr. Lorian, is that you? Okay. I'm impressed with all of you, by the way. But when you said something about the Minnesota statute under the Department of Human Rights, you hit the nail on the head. Because we need to amend those laws to include other languages. And why hasn't that been done? Because people don't think that way. This country was built on racism. And so all those statutes are so old, nobody really thinks to amend those things. So I really appreciate that, especially the 1964 Civil Rights Act. Implicit bias, I also want to state that it's very important for people to understand the differences in the languages, the many Hmong languages, the beautiful languages of Somali, some of the Somali population. You know, you have to understand that there are so many differences within the culture itself, and to acknowledge that. One of the things that Kathy talked about as well is that there's a universal language of just kindness, respect, eye contact, making that effort that makes all the difference in developing trust with your clients.
Thank you. I appreciate that. And you're absolutely right, when it comes to mental health, we haven't spent much time here on mental health at all. And we know that that is a very significant component of sort of the health landscape, so to speak. So I thank you for calling us out on that. Any other questions? Yes.
Mine is not a question, but in addition to my colleague Jennifer there, being a nurse at the bedside of a patient coming out of surgery and working with a patient going in and out of surgery, it's good to be patient. Nurses can be detective and kind of be all kinds of things in order to fulfill the treatment regimen for the patient coming in. A few times I've found myself in situations, I'll give 2 or 3 examples in order to take your time. I had a patient who had a hysterectomy and had a stroke in the past, but is a person that was very active, still like to be self-sufficient, go to work and back. But she needed that surgery. Surgery was done, but had going home, somebody have to be with you for 24 hours for your own safety. Didn't have anybody. Here the person that was going to take her home is her brother. What does the brother know about women's surgery? And I'm noticing she wasn't appropriate to go home that time, so I became an advocate for that person. I tried to put myself in that person's situation. If it was me, would that work? So I took one step further, consulted the doctor. This is what we need to do. What do you think? And started doing research. She ended up staying in the hospital. Another thing, not to be judgmental and try to understand somebody else's situation. Like a homeless person came into the hospital, had a major surgery, TIPS procedure. Usually, people like that, they have a bleeding tendency. But nobody had found out that that person was homeless. And she was supposed to stay in the hospital at least for 1 or 2 days to make sure that she didn't have any complications that could be life-threatening to her. So she came to the recovery room. I happened to be the nurse also. And she just wanted to go home. I tried to reason with her, tried to explain to her. I even had tears in my eyes, thinking that this person might die if she goes home. And she didn't care. As far as she's concerned, her problem was taken care of. She's ready to go home. Didn't care about the complication thereafter. So I tried to explain and plead with her. She just wanted to go home. Then I asked her, why do you want to go home? I found out she was homeless. If she didn't go to the shelter tonight, she would have lost that opportunity. So the surgery is taken care of. If she goes now, which home is she going to be going to? See, and then with other cultures, like the Muslim culture, thank God I'm from an area where you have both Christians and Muslims. Sometimes learning those little clues help me in my nursing. I know a Muslim woman is coming out of surgery, usually they want their head covered. So immediately I know I have to have one blanket. My colleagues would ask me, why do you have to do this? I said, this is the culture for them. They like to cover their head. It will make it better for you and for her. And you have other culture, like I think Asian or other culture, they, after surgery, they'll ask for water to drink. I was just sharing that with my friend here and asked them, how do you want your water? Some people want it warm, don't give cold water. We Americans, we always want to drink cold water. So warm water is good for a certain culture. They don't want cold. And little clues like that help. But to put things together, patience, and putting yourself in that person's shoes, how would I would I want somebody to treat me if I were in their shoes? So, do unto others as you like others to do unto you. Put yourself in that person's shoes and be very patient, not to be judgmental, and also know there's a heart for somebody out there. So that's, I don't know if you can say that.
Amen. You hit it. Thank you. Thank you. Amen.
Hi, my name is Danae, and thank you, Jen. It was nice to meet you. The nurse walking the line for the patients, actually, advocating for the patients, and the other nurse who just spoke. So they're at the bedside, so who better to understand like myself. I'm a psych nurse, I work in mental health, and it was new to me. I didn't know the video interpreting was going on, and I think there's pros and cons to that. From an emergency standpoint, you need immediate access. It's better to have a legal interpreter there, not a family member. So we meet the needs of the patient, what the patient truly wants, because that's why we're there, and for their patient bill of rights. And also, my concern with the videotaping service, though, in the hospital, I've never heard of videotaping interpreter until now. But I know in mental health, that can't take place. It's a sensitive topic, a sensitive issue there can't be any of that in mental health issue. Like, we can't even let the family members or people know that the patient's there unless the patient signs a release of information. So I really appreciate, I forget her name, who spoke here too, in the mental health field that she works in too. We have to be really extra sensitive to that and those types of things. But I think the thing that I kind of take for granted, because I work in a healthcare system in the hospital, they have all that stuff set up. They have an excellent educational thing on what they call the InfoNet. I can just access as an employee. We can contact the interpreter right away. And I think somehow the gap is, okay, so we have it set up in the hospital. How can we get that out into the community? What has the hospital system done to better meet the individual needs of the patient? And what can we do to do that out in the community now? Because home healthcare field is growing, our population of diversity and elderly is growing. So how can we bridge that? And I think the community needs to contact some of the hospital systems. I think Health East has a good system set up, maybe to bridge that gap. But you mentioned a co-op that the hospitals have, that I think that would be kind of good, and maybe the community could access that. I know when I've done home care visits as an RN, we've had interpreters there. And I would not feel comfortable for patient advocacy, because there was relatives there, and also my RN licensure from a legal standpoint, unless there's an interpreter there. So, but But I just think that might be a solution, the community contact in the hospitals, okay, what's worked? And how can you tailor that individually to the community? That's a possible solution, but it was nice to meet you, Jen, and the nurse who spoke at the bedside talking about her patient now, so thank you.
Before you sort of hand the mic over, is there anything in the mental health piece that we have missed that you'd like to at least put out there? You don't have to do it right now, but feel free to think about it, and if you need to add something, we'd love to hear it.
Well, I think the videotape and interpreting is not a good thing for mental health, because a lot of times these people, they're at their worst and they're in the most vulnerable situations. I've had personal family members in the psych units, and I would not want some videotape and interpreter, because just with the technology out nowadays, you just never know. But in an emergency situation where they need it, in some given situations, I understand where they need it, but then in other situations, they shouldn't. And I guess that's the only thing I can think of right now, but the sensitivities to the, because they have an individual, they have a separate Bill of Rights too. There's what we have to go through, separate, unique rights for them beyond the patient Bill of Rights.
I have a couple of responses to that. Just to clarify terminology, it's actually not videotaping, which implies recording for posterity. It's a video interactive situation. And also in the rural hospitals, we actually do, in the emergency department, psychiatric consultations via video. The patient sends a list of information to interact with a mental health assessment person. The hospital has a contract with that. As a matter of fact, one of the hospitals in particular has a contract with Abbott. So they're actually having the mental health person that helps me assess if this patient needs hospitalization or not. That assessment is happening over a video system similar to video interpretation. I do not know all the ins and outs of how to protect patient confidentiality. In my opinion, protecting patient confidentiality in the person who has abdominal pain and speaks Samoan is the same as a person who speaks English and is there for depression. It all is confidential, so it has to be a confidential system even though it's going over the video on the internet.
Right.
If I can add a piece, since mental health services have come up, this has, as you imagine, an extreme layer of complexity in the whole, if you ever go through an interpreter. And in some regards, I want to say don't go through an interpreter. Actually, we have very good direct services. And I think one of the mistakes that we make through some of the health systems is we've got to provide this service. Somebody comes in for crisis care, well, we have this crisis care service, so we've got to provide that service, even though maybe it's a Lima who's saying that, even though Regions has a deaf-centered health, crisis health service. So they can have somebody providing direct service, as does Fairview. Riverside has services. Fairview, Riverside, we're the only place in the country that has an in-hospital chemical dependency program at Riverside for deaf people. And there are deaf therapists there. And you know that we've been talking a lot about interpreting services, and really the ultimate is direct services in your own language. And we really, that's, if Northwestern could do anything, it's recruit more Hmong therapists, more Hmong speaking therapists, more Arabic speaking therapists, more Somali speaking therapists, more ASL using therapists, you know, deaf therapists coming in and learning the trade so that they're providing direct services. Because I would love a world where I worked out of existence in a way. Because interpreting is never the best solution. But if an interpreter is being used in a mental health, where mental health is an issue, that's even more an important time for the interpreter and the therapist to have a pre-conference, so that the interpreter knows clearly what is the goal of the interaction. Because the whole thing is, you know, the issue around identifying what the problem may be is through communication, and it's the nuance of communication that is so critical. And how is a person saying something, not necessarily what they're saying. or what they're not saying. And that's what the therapist wants. And if the interpreter doesn't know that, it's totally going to be lost or masked to the interpretation. So I just wanted to add that.
I'll take one more question or comment. We are running out of time.
I just want to say that with the mental health, I know that like for the video interpreting, with mental health population though, it's a lot more sensitive than someone who's getting their abdominal or whatever other procedures they need done. That's why we can't just let people know who's there. And I think the drawback with videoing interpreting is that you get a paranoid schizophrenia who's paranoid about monitors and TVs, and I think they're being watched. So I think for mental health though, really to have an actual person there is the best. And video interpreting should not be allowed for mental health issues. If they're, because then you have the legal aspect of are they mentally competent to make that determination, and that's where I'm not for that. But I think for other situations, it's great, emergency situations, so.
And I'm just going to, because Catherine brought up an excellent point, that's a struggle that we're really facing right now. And places like Essentia Health, which is a provider, it's the conglomerate that's kind of taking over all rural health in northern Minnesota, northern Wisconsin, the UP of Michigan, all the way over to Montana. So the clinics are far and few between, and they're housing their interpreters in Duluth and Fargo, the big population centers, and they're trying to figure out how to best provide that interpreter support, and oftentimes it is through VRI. But what I really appreciate in the Essentia system, they've created a protocol where they clearly outline what is going to be the process for using VRI, video remote interpreting, versus an on-site interpreter. And they have a structure, and the patient is brought into it in the conversation. And it's fully explained to the patient with an on-site interpreter, and so that the patients agree to how the VRI might be used. And I know exactly what you're talking about, and you're right. But both of us come from northeast Minnesota, and the reality of living in a rural, remote community is one that really adds another complication to this whole service.
I just want to make a short comment about that. Thank you. My short comment about that is just that if that's going to be done, I appreciate that, but don't put the client, this is the message I would like for everybody to hear, don't burden the client with that process. Have it already up, running, ready to go. Because that client is that client. He or she is receiving services from that provider. It should not have to provide their own advocacy.
I'm going to push back on that. I appreciate that. But from all the work, and I guess I would really be interested in your response, for my work with deaf consumers, while they don't want the full burden of advocacy, they do want to exercise some self-advocacy when possible. They want to be able to be a partner in the decision-making process, especially when it relates to their healthcare and the communication aspect. So I would like to know your perspective of how much do you want to be involved in that decision-making process when it comes to how the provider is communicating to you?
Me specifically involved in the process? I'm going to say it really depends. If I'm going to be involved in the process, then yeah, I want to be fully there. But oftentimes if there are issues, then I want it to be worked out with supervisors or other people specifically. I can think of maybe 2 or 3 years ago, I went to HCMC, I was having chest pain. And I let them know that I was deaf, and my fiance was there with me, and she interpreted just a little bit in that situation to help make communication clear. And so they told me that they were going to find an interpreter for me, and I sat down and was waiting, and I was in pain. And they told me that the interpreter would be there, but I'd have to wait for 2 hours. And that wasn't going to work. I was like, is there anybody else that we can find? And they said no, that this was the only person on the list. And they said, well, we could do video remote interpreting, but that's not going to work just because of the issues I had before. So I went into the room, and my fiance ended up interpreting for me because it was a very brief interaction. So I'd recommend in those situations that the health system just needs to get better. It needs to be more equipped. So that we have equal access for deaf people. And just everyone, really, not just deaf people.
One last question, yes. One comment.
So, no, I have a question. Should there be a state-run program to provide these services, or do you think it should be private? What do you think would be more cost-effective or beneficial for the patient and the providers?
I can tell you the history. When I came into the field, there was a state system. There was a central, and this was prior to spoken language interpreting services being provided by any place other than Mayo. Mayo has provided services since 1917, I think. But we had, through the Department of Human Services, a state-funded interpreter referral center that provided access throughout the state for sign language interpreters. Some limited services were paid for by Department of Human Services, but a lot, the bulk, they would provide the free referral and placement of the interpreter, but the interpreter still billed the agency directly. So that was the historic model that we had. In 1985, that got outstripped. The state couldn't afford it anymore. And it was a budget, I think, of $200,000 annually to support that system, and it just got, the need got outstripped really quickly. So Massachusetts is the one state that still has a state-supported referral system, and they're just having problems across the board because they can't sustain the model. The community has fought very hard to keep that model in place, but they keep dropping out pieces where they used to provide services for all medical, private practice doctors and chiropractors, health providers. They took that out, I think, 5-7 years ago. They just can't. It can't be a sustained model because the demand keeps increasing.
Very interesting. So I would like, again, because we're really short of time, I'm going to ask you to cut your comments to 30 seconds instead of the couple of minutes I've given you. But if you had 30 seconds to share your solutions for bridging the gap, I'd like each of the panelists to take 30 seconds, if you wish, and share what those might be.
So I think the best thing you can do, honestly, if you're a healthcare provider and you want to bridge the gap, is travel so you can experience being limited by culture and language, so you can have actual empathy. And then once you've got that experience, when you're in the room with a patient, smile, try speaking another language even if you're terrible about it, give yourself permission to goof up, and then learn from your mistakes, and learn to ask when you've made mistakes.
Dylan.
Here at the school, first of all, I just want to thank, we have a lot of people here from the school. We've got faculty members, we have students, alumni, and staff members here, and I want to say thank you all for coming. Also from the school, first of every trimester here at the university, they were called Faculty Development Day. We also have monthly care conferences, which we can focus our topics. And one of the groups, the occupational medicine group, this last time around, actually in September, they invited the partners that we have out in the field, from the hospitals and from the care units where we have our interns that are learning their craft and being supervised to provide care, and have that dialogue in many ways. But I'd like to open that up more fully, I think, here at the university. Also with the care conferences, I would love to have this kind of a
panel presentation to outline some of these things that we have right now with the care that we provide and the patients we see to our students, to our employees, and to our overall to our campus community. So thank you. Sure.
Okay, I may be a little bit of a rebel on this, but I personally, as a language teacher, recommend that all programs require language one semester of it as part of their program, especially in the math and sciences, especially in the medical field, one semester. And basically get the intro beginning piece of the language, but what you really get from that is a lifetime experience of how it feels to be in a situation where you don't get it, where the information doesn't really get through to you, and you have to try to figure out how to make things work. And this is not about language learning, this is about situational learning, and learning how to be empathetic and sympathetic to what you will experience in your field in the future. So I recommend this, but I don't know how it's going to go, but I just feel like language opens up doors and windows and gates to everything else that will be to come, in the position as providers, and one semester is what I recommend, but.
Just enough to know what you don't know, right? Yeah, that's a good. I wholeheartedly agree with that. I think learning a second, third language is vitally important just in our culture to broaden our world knowledge, which is sorely lacking right now. I also want to put a plug out there again for recruiting from communities to draw in more diverse providers. It's something that we really need more actively pursued. And I can't think of, there's one other thing that I forgot. It's been great talking to you all today.
I agree with everything that was said, and about the diverse providers obviously starts with our children, and just encouraging children that they can become whatever, it doesn't matter what color they are or what racism does exist out here, just encouraging people to overcome that from children on. That'll get us some more, hopefully, diverse providers in bigger numbers. And yeah, traveling's huge, and just again, remembering the human piece and setting your judgment and your any kind of racism or anything you have within yourself aside, and just loving people and always treating them like yourself or like your own mother. That's how I treat all my patients, like I would my own family. And I want to deliver the best care, 200, 300, 400% top-notch, best care, so people come out just feeling better because of what you gave. It doesn't matter what language. Even I did some nursing in Guatemala for a mission trip, and I speak some Spanish, and I use some of it to reach to people, respirar profundo, or in the recovery room, but there was still a connection. I didn't have to speak their language. I treated them, and I could read grimacing on the face, I could read body language, I could treat their pain or their anxiety, or show them my cell phone. Some of them had never seen the show them a video. Well, some of the kids wanted to see, what's that? There was some big singer coming to Guatemala City. They'd never seen a TV. Just reaching people in a different way. Or some of my Russian patients, I love going to the Russian museum. Like you had said, just finding that, or one of you had, finding that common ground, even if you aren't from the same culture. Talking about the Russian museum, and one of my favorite portraits in there of the milkmaids, like made a connection with the Russian patient or the Russian orchestra. Just, going out within our own community. We have such a culture here. And there's many things that you can go discover within Minneapolis, St. Paul, surrounding areas, and find culture. And just not judgment for even somebody I come in who comes in and is a meth, addicted to meth. I'm going to treat their pain. I'm not going to hold back. I'm going to treat their pain even more diligently than I would even somebody else's, because they deserve that, even though they've found themselves addicted. No matter what, it's always that extending to them, no matter what they've chosen or path they've chosen in life, peace, love, extending that non-biased delivery of care to everybody.
I agree with everything that's been said. It's been great. My hope is that the health system will get better and just have more access for everyone. That education of doctors and education of patients too would improve so that we can communicate more comfortably and more easily rather. And then third, what was third? I had a third. I don't know what third was. So
Well, I would just like to say a very special thank you to the panel, Mr. Zillett, Dr. Kramer, Dr. Casella-Maddox, Ms. Magmore, Mr. Lorian, Ms. Avalon, Mr. Sandberg. We have all gained from sharing your time with us today. I'd also like to especially thank you all for being here today, for taking out this morning to learn more, to broaden your own scope of knowledge so that we can better serve our patients. I cannot close the day without thanking two key people. And she said I must not thank her, but I'm going to. She's standing over there by the mic. Mai Yang had a huge part of it. I realized I wanted a boundary, but I had to do it. Ms. Donna Sandberg also has really He who has health has hope, and he who has hope has everything. Thank you.